I think it's very, very difficult as a GP in the situations you're in with just an oroscope looking into an ear to get a full grasp of what's happening in an ear. And my hats go off to you guys. You know, I have a wonderful microscope and a sucker. I can clear all the debris out the way, whereas you're looking past a bit of wax trying to get a view. It's difficult. But for me, there are a number of key things that I think you should look for. One is if someone does present with a sudden hearing loss. So overnight the hearing goes, sometimes associated with a bit of dizziness, bit of imbalance. The commonest thing that causes hearing loss, in your experience, I know, will be some form of blockage of eustachian tubes, so a cold, and therefore you treat them with nasal decongestants. But a really, really simple way to work out whether this is actually a blockage or coming from the cochlear is tuning fork. Put a tuning fork in the middle of the head. If they can't hear in this ear, or the problem is in this ear, and when you put the tuning fork there, it's heard there, it's a conductive loss. If it's heard in the other ear, that's a sensorineural loss. That needs to come to hospital straight away for steroid treatments. These days we do intratympanic steroids, and we can rescue the ear very often. The other thing is intractable pain, particularly in the elderly patient with recurring otitis externa, keeps putting the hearing aid back in, keeps getting infections, blah, blah, blah. Just think about whether there is actually a chronic, a malignant infection. This is where you get an infection into the bone of the skull base, and it starts working its way along the skull base to take out the lower cranial nerve. So just have that for the elderly patient who's just getting recurring otitis externa. Other conditions which I think GPs worry about are cholesteatoma, acoustic neuromas, and all this. They're incredibly rare. A lot of the patients I see who come to me with an asymmetric loss, and anybody who's got an asymmetric hearing loss, we do need to see them and we need to test them, and we may need to do an MRI scan. But probably one in several thousand MRI scans I see are positive for an acoustic, so it's incredibly rare. Cholesteatoma, think about it, and when you're looking in an ear, look up at the top, look in the attic, don't look down at the drum. It's easy to look at the drum and think that's normal. Look up in the attic and just check there's nothing going on there. But again, I think they're unusual to miss, and therefore I think overrepresented in GPs' anxieties. A lot of GPs worry about missing mastoiditis. In my experience, it's incredibly rare. I've probably only seen about 5 acute mastoiditis in my entire career. So it is rare, so don't worry about it. And it's actually quite easy for it to be masked because you've had antibiotics and the ear is, you know, getting better, but it's still a bit sore behind. So if you have any anxieties about mastoiditis, it is rare, but if you do have any worries, send them in and we can see them and we can tell you what's going on. So in summary, when you're looking at things that you're worried about in the ear, be aware that you don't have the best facilities to do it. So don't worry about sending somebody in if you're at all worried. Intractable pain in the elderly patient, think it could be malignant otitis externa. A sudden hearing loss, don't just assume that it's a eustachian tube problem. And thirdly, anything going on around the drum, if you can't see it, send it in and we can have a look at it for you.